Fantastic. Right. So first of all, thank you. Thanks a lot, Flaminio. Thanks a lot, Alessandra Marengoni, for the invitation. It's my pleasure. I mean, I'm enjoying this morning enormously. So thanks a lot, really. You said Kungsholmen perfectly. You said Larrañaga perfectly also. So there is only one detail that I need to add. Today I will be speaking about social network, of course, but in association with different outcomes, or slightly different outcomes to the ones that we have been speaking about during the morning, which are related to cognition, cognitive function, cognitive decline. In this case, I will focus on multimorbidity, morbidity burden, or in other words, the coexistence of multiple chronic diseases, which, as you know, is the norm rather than the exception in older people, and also physical function. So now for this 20 minutes, we're going to shift a bit from cognitive function to physical function and diseases, to more physical domains of older people's health. The reason why we thought it could be interesting is because I think it may provide complementary insight into the discussions that we are having today. I hope you also find it interesting. In any case, all of the 3 studies that I'm going to present today are based on data from SNAC, as Flaminio said, the Swedish National Study on Aging and Care in Kungsholmen, which is a neighborhood located in the center of Stockholm in Sweden. So my name is Amaia. I'm associate professor at the Aging Research Center, and I think I will start with a brief background or the conceptual framework as to how and why we operationalize our outcomes. So I'm going to forget just for a couple of minutes about the social network for now. I will come back to that later. I now want you to understand the reasons why we look at our outcomes related to multimorbidity and physical function the way we do. So this graph on the top left-hand side is showing us it's a very simple illustration of how phenotypic age, which is nothing but the anatomic and physiological changes that happen over time. So we see here what this trajectory would look like, as we become older in chronological terms. So you see that there is an average here, but of course this average has a wide interval, meaning that there is heterogeneity around that average. And we see that that heterogeneity is quite small at earlier ages, but of course that heterogeneity becomes huge at old age. Another interesting thing here is that this trajectory of phenotypic age is actually an equilibrium or a balance between external stressors, what we call entropic stressors, and resilience mechanisms. So basically those mechanisms that enable us to restore order. What is interesting is that the speed at which this phenotypic aging takes place differs depending on the dimensions of aging that we study. So first comes the biological aging, then comes the phenotypic aging, and in the last place and in the latest part of our lives comes the functional aging. And the speed at which each of these happens depends on the speed at which our reserves, different types of reserves, different types of resilience mechanisms are depleted. So basically, functional aging comes at the very end when all resilience mechanisms have been exhausted. Now, you may wonder, why are you speaking about resilience mechanisms? Why are you speaking about phenotypic aging? Why are you speaking about these 3 different dimensions of aging? And this is because our understanding is that if we are able to operationalize this phenotypic aging in some way with the data that we have, and in second place, if we're able to understand what are the mechanisms that accelerate the depletion of those homeostatic or reserve mechanisms, well, then, of course, you can understand that we will be able to prevent or delay the speed at which this aging happens. And of course, this implies a shift from traditional medical research, whereby we have often focused on damage and risk factors, towards a perspective where we try to look at those factors that enhance resilience. Now, in our research, and bearing in mind the definition of physical resilience, which is the ability to recover from functional decline in the face of stressors that disrupt normal physiological homeostasis. There are many ways of measuring physical resilience, and in our research we have chosen this alternative. So this would be the trajectory analysis, would be how we have analyzed our outcomes across the 3 studies that I will present. What does the trajectory mean? Well, this is basically measuring the speed at which people develop either chronic diseases, either functional limitations, or disability. And that's the first part. And the second part, and here comes the social network, what we want to know is, okay, and what are the factors that contribute to, what are the psychosocial factors, and more specifically, what are the social well-being factors that would contribute to these differences in the speed of multimorbidity, physical limitation, or disability accumulation over time? So that is a question, that is our frame, and that is where the 3 studies that I will present are embedded. And just to finish with the background, I want to show you that indeed, not only in the Swedish National Study of Aging and Care in SNAC, but also in other data sets, we do find an enormous heterogeneity when it comes to these differential trajectories of disease and functional limitation accumulation in older people. The figure on the left-hand side is based on UK primary care data, and these authors identified, across a follow-up of up to 12 years, they identified 5 different trajectories of multimorbidity accumulation, of chronic disease accumulation, that they named non-chronic morbidity, onset chronic morbidity, newly developing multimorbidity, evolving multimorbidity, multi-chronic multimorbidity. But the same happens with functional decline, and this is data from SNAC. We show that whether we measure walking speed, one precise and objective measure of physical function, or whether we measure the development of limitations in activities of daily living, there is a heterogeneity. There are indeed different ways in which people evolve over time, in which people accumulate these limitations over time. So there is reason to believe that if we're able to capture these differences in the speed at which people accumulate chronic diseases or functional limitations or disability, these could be considered as proxies of the speed at which these resilience mechanisms are depleted. Or in other words, they could be considered, these trajectories could be considered as proxies of biological aging. So that is our motivation behind the study of these outcomes in the form of trajectories, longitudinal trajectories, change over time. For that, we use data, as I said, from the Swedish National Study on Aging and Care, and this is what the flowchart looks like. So this is a population-based cohort study, which is still ongoing, it's based on people who live in the island of Kungsholmen, which, as I said, is located in the center of Stockholm. And these people were aged 60 or older at baseline, and baseline took place between years 2001 and 2004. And ever since people have been interviewed either every 3 years, as you see for people that were 78 or older at baseline, or every 6 years for people who were 72 or younger at baseline. So depending on the baseline age, baseline or follow-up age, people are actually interviewed every 3 or 6 years. In each of these interviews, in each of these waves, people go very exhaustive interviews that cover different aspects of social, physical, psychological, and neurological health. And indeed, each of the subjects, each of the participants in SNAC undergoes 3 different interviews, one that is led by a nurse, one that is led by a physician, and one that is led by a psychologist. There were in total 3,363 people who participated at baseline. And you cannot see here, but it is a dynamic cohort in the sense that there are new cohorts, new age cohorts that are incorporated during follow-ups in order precisely to face attrition, which is unavoidable in aging cohorts. I have to say also that SNAC data is linked to the Swedish National Patient Register, which gives us all of the diagnosis and all of the clinical activity that is related to the hospital and outpatient specialist setting, but also to the National Death Register in such a way that we know when and why people die. So this is SNAC, and a bit more about the methods that are common to the 3 studies that I'm going to present. As I said, the outcome will be the rate of either chronic disease, functional limitation, or disability accumulation over 15 years. Some studies will look at a shorter follow-up, some studies will look at a longer follow-up, but it's a maximum of 15 years. So basically, I'm using the 5 first waves of SNAC. I will give you a bit more detail about how I am operationalizing social network in these studies, but basically there are 3 main components: the social connections, the social support, and the social participation components. We exclude people with dementia or an MMSE below 24 at baseline, and this is because all of this information about the social network is self-reported, and therefore we want to avoid any kind of measurement error here. Precisely to see whether this reverse causality is or not an issue in our studies, we replicate our studies removing people with prevalent multimorbidity or disability at baseline by starting with very healthy samples. And we usually use linear mixed models, looking at the interaction of each of these exposures with time in such a way that we interpret the association between our exposure and the change in the outcome. Now we adjust all of our models by, not in every study, but this is these are the variables that we usually take into account. So sociodemographics, sex and age, education level, time to death or dropout, lifestyle related to alcohol consumption, smoking, cognition through the MMSE, depressive symptoms through the MADRS, which is a tool designed specifically in Sweden, measuring the number of depressive symptoms. We also take into account underweight and the number of drugs, precisely to account for that underlying frailty that we would not capture through other health dimensions. And we also adjust our models by personality traits. So this is about the methods. And as I said, now I'm going to focus a bit more on what is our common interest today, the social network index. As I said, there are 3 dimensions that we measure. Sometimes we look at them separately, sometimes we look at them together. The social connections are going into the quantitative aspect of the social network in terms of the number of living children, the marital status, the living arrangement, and this is specifically to capture whether people are living in a nursing home or in the community. And then come the questions about how many people you feel you know, and how many people or with which frequency you contact each of these specific people. That's about the social connections. The social support part is about the qualitative aspect of the social network. So how satisfied you are with the above mentioned contacts, and whether you would be able to get specific types of help in case of need. So, help for practical troubles or illness, help appealing a government decision, help, emotional help, etc., etc. And then there are some questions that query about the sense of belonging of a person, of the proband, to the community, to a group of members, to a family, to a group of friends, to a neighborhood, etc. And then the last dimension is about social participation, and is asked by a simple question. Basically, we ask participants whether they have participated and with which frequency they have participated on any of the activities that you see listed below. All of these activities are supposed to have an important social dimension to them. And what we do, and this is following the recommendations by Cornell and colleagues who have worked using the National Social Life, Health and Aging Project. What we do is that we transform each of these questions we standardize them, we transform them into CETA scores, and we later average them across these individual 3 dimensions of the social network: social connection, social support, and social participation. Whenever we want to look at the social network as a broader, more generic exposure, we would then go and average the 3 dimensions, social connection, support, and participation. So that's how we study social network in SNAC. This is the data that we have. And we have this data collected for baseline, but also for follow-ups. So I'm going to start with the first study, for which the lead author is Sergey, and this was published in the American Journal of Epidemiology in 2019. And the title is Association Between Speed of Multimorbidity Accumulation in Old Age and Life Experiences. And this is a cohort study. And in this study, well, as the title itself explains very nicely, we try to look at different, what we call life experiences throughout the life course. So in early life, midlife, and in old age, or in later life. And our outcome here is precisely the speed at which chronic diseases accumulate. And I think now you understand why we operationalize our outcome in this way. In this case, we followed up people for 9 years. So for the 4 first follow-ups of SNAC, this is because the 5th wave was still not available. And we looked at 4 different exposures or life experiences. One was father's occupation during childhood. So that's, an exposure that belongs to the early life. The second one is early adulthood education. The third one speaks about job strain in midlife. And the last one about social network in late life. So basically, while A, B, and C are captured, either early in life or in midlife, D, which is social network, was measured at baseline. So at the first SNAC interview between 2001 and 2004. And then our x-axis is follow-up time, and our y-axis is precisely the estimated number of chronic conditions as time goes by. And so what we saw in this study is that indeed having a university education versus an elementary education, having an active job compared to a high-strain job, and here an active job is defined as the one that whereby one has a high control but also a high demand, whereby a high-strain job would be that implies a high demand but a low control. So indeed, active jobs versus high-strain jobs would also imply a slower accumulation of chronic diseases. And last but not least, a large social network versus a small social network would also imply a smaller or a slower, accumulation of diseases across time. So in this case, social network was measured as an average of the 3 dimensions of social connection, support, and participation, as I said. And I repeat, in this case, it was only measured at baseline, while the outcome, which is the accumulation of chronic diseases, was measured across the 9 years of follow-up. Another interesting finding from this study is that we found a significant interaction between midlife job strain and late life social network in such a way that compared with a worst category, so high strain, poor network, those with rich network, but also a high strain, would also show a slower speed or rate of chronic disease accumulation. We could interpret this as if, this social or rich social network at the end of, in late life could compensate for the harm or the risk effect provided by this high strain job. Right, so that's about the first study. I'm gonna move now to the second study, which is slightly similar, but with a different outcome. This was carried out by Margarita Sadek, a PhD student working in my team, and published in the Journals of Gerontology in 2020, last year. And here we're looking at the role of psychological, but also social well-being. And in this case, we're looking at the physical function trajectories in older adults. So not the speed of chronic disease accumulation anymore, but rather the speed at which the physical function of older people declines over time. Social well-being, again, is an average measure of the social connections, support and participation dimensions that we spoke about earlier. And here we also looked at another exposure, which is psychological well-being, which is again an average of standardized measures of life satisfaction, positive effect, and negative effect. And what we found, first, I need to clarify that our outcome here was a global score that we built, averaging together 3 different measures of physical function, which were walking speed, balance, and chair stance. And we considered that these 3 measures, which are, by the way, part of the SPPB, which is a common standard measure of physical function during the comprehensive geriatric assessment, they give us a good idea of aspects related to mobility, muscle strength, but also balance. So it's a comprehensive way of measuring physical function in old age. And what we found is that indeed both a high level of psychological well-being, but also a high level of social well-being, again, a high level of social network, because this is how we measure it in this study, actually leads to a slower decline in this global physical function measure that I was speaking about before. It was clearly significant for the psychological well-being, and it was borderline, but with a clear trend for social well-being. And of course, all of these models were adjusted by sex, age, education, time to death or dropout, presence of any chronic disease at baseline, alcohol consumption, smoking, cognition, depression, and personality traits. And in this case, the follow-up was a bit longer. We were looking at the outcome across 12 years. It's also interesting to see that there was a significant interaction with sex, in the meaning that this protective effect of a high psychological or social well-being was even more pronounced among female, in the sense that female with a high psychological or social well-being showed an even slower decline in physical function, especially at the beginning of the follow-up. This difference was slightly faded away at the end. And we also checked for potential interactions between these both dimensions, the psychological well-being and the social or social network index, by creating an indicator variable. And we do see indeed that compared to the low psychological, low social category, well, those with a high psychological and high social well-being are the ones who are benefiting most from this slow decline in physical function. So this is the second study, and now I'm going towards the last one. This was published by myself in 2018, a bit old now, but I think it nicely puts together the results from the 2 previous studies. Alessandra was also involved in this study, by the way, that we published in the Journal of Internal Medicine. And what we wanted here was to first look at the association of rapidly developing multimorbidity and disability accumulation over time. That was the first objective. And the second objective was to see whether different measures related to the social background, among which we also looked at social network, would kind of moderate or modulate this association between multimorbidity and disability development over time. So we were able to distinguish 2 clearly different groups in terms of the speed of multimorbidity accumulation. The red line, rapid accumulation, the blue line is slow accumulation. And we see that indeed, of course, as expected, those that are accumulating diseases faster are also developing both ADL and IADL limitations faster too. And what is interesting is, and also perhaps expectable, that the change or the accumulation or the speed at which these diseases accumulate is a far better predictor of the disability development than just the baseline measurement of multimorbidity at baseline. In this case, the follow-up was of 6 years. So we focused on the 3 first waves of SNAC. And now here comes perhaps the interesting part, because what we wanted to do in second place, as I said before, was to check whether there could be any moderating role of different variables related to sociodemographics among the 4 that we included in our analysis, which were sex, occupation, education, and social network. And what we see is that there is a clear departure of two trajectories here. One that is for women with a rapid accumulation of multimorbidity. So you see that this line here, the red interrupted line, people in this trajectory are accumulating disabilities a lot faster, but also people in this line. And these people are people with a fast accumulation of chronic diseases, but also a poor social network. Again, here I'm looking at social network as an average of these three dimensions. So this again speaks for an interesting potential protective role of social network in terms of providing people with increased resilience mechanisms that could make them develop disability slower despite a rapid accumulation of chronic diseases. In terms of the finding related to sex or gender, we link this to the well-known male-female survival disability paradox, whereby women would be less likely to suffer from fatal diseases, but more likely to suffer from disabling diseases related to frailty, geriatric syndromes, etc. And again here, this is another way, through this forest plot, I wanted to show you that the highest adjusted incidence rate ratios for disability development were seen for people with a rapid multimorbidity accumulation, but also a poor network, and in this case, for women. And I think that's the summary of my 3 studies, and I'm going to go for the conclusions now. So we do see consistent findings across these 3 studies in the sense that factors related to the social network would be associated with the speed of multimorbidity or chronic disease, functional limitation, and disability accumulation over time. And of course, we could discuss about the mechanisms whereby this happens, but we believe that it's most likely a multifactorial scenario whereby multiple factors related to health behaviors, cognitive reserve, stress-related mechanisms, but also material support and access to resources and the material goods would also be playing a role. If we believe that these trajectories of disease and disability accumulation are actually windows into resilience because they would be proxies of the speed at which these reserves are being depleted, well, then it's quite interesting to see that all of these life course factors do actually affect the rate at which this reserve is being depleted. And I think a special mention needs to be done to the social network because precisely it has a modifiable character, and therefore it brings a possibility to think of different interventions to slow down basically the biological aging of older people. In terms of the implications, well, from a health policy perspective, this clearly calls for an intersectoral action for health. It goes without saying, but also for the need to wear the health in all policy glasses when we think of the evaluation of any type of intervention. And in terms of clinical practice, well, again, the relevance of all of these contextual and biographical factors speaks for a clear need for a person instead of disease-centered care. And I think it also opens new research questions and new potential research lines in terms of better understanding what the clinical meaning of this rapidly developing multimorbidity or disability means, and whether there exist any specific thresholds beyond which people would be experiencing this multi-system decline. And of course, not only that, but also by looking at factors that would increase the risk of attaining those thresholds. So this is all from my part. I would like to acknowledge the financial support received by different foundations and agencies, the SNAC-K data collection staff, the participants, our medicine sector at the Aging Research Center, where Alessandra is part of too, and of course to all of you for your attention. Thanks a lot.
So thank you very much, Amaia. Very inspiring, and very happy that you made it. And any question? We are running a little bit out of time, but we can save a little bit of minutes from the final discussions. Any question, Amaia?
I have a comment question,
please,
if I may. Thank you, Amaia. Very nice presentation about the results of the past years from the SNAC data. And I know very well that SNAC can provide you with a lot of information, and this is a particular strength of the study, of course, that you can carry out. So my comment is about the adjustment that you can apply to the analysis with a lot of factors which are very important to adjust for, and also for personality traits, which I think is quite important. So my question is, does it change a lot, the model adjusting for personality traits? Thanks.
Thank you. Yeah, very, very good question. The short answer is it is significantly associated with both the exposure and the outcomes. So that's why we tend and we keep adjusting by it. Now, the changes that we see, there is not a huge attenuation of the associations. So we're also happy to see that, you know, the associations that we see are quite robust and independent, definitely, from personality traits, which consistently predict different outcomes, whatever we're looking for. Yeah. But we realize that this is rarely accounted for in other studies.
Thanks.
Yeah. Mm-hmm.
Okay. Any other question? I assume one of the question is how to incorporate the network concept that we have seen in a previous presentation in your data collection, if ever possible, probably.
Yeah, I'm already starting to think about that. It was very inspiring in that sense. So in this work, we have looked at all of the dimensions averaged together, but we also have some work looking at the different dimensions, you know, the social support and the social connections part, especially. The truth is that we don't see any clear pattern in terms of what would be more protective, which one of the two would be more protective for specific outcomes. I mean, we usually see that both play a role, and perhaps depending on the outcome, sometimes we see that one might have a bigger effect size than the other, but no clear patterns so far. Of course, I understand, and especially after listening to Federico and Lea, that, you know, the way we measure this social connections, or the quantitative and the qualitative part, are quite, how to say, rough. So there is still room for improvement there. Yeah.